Hey, thank you very much, Jack, for your kind introduction. Good morning, professors, fellow panelists, and dear colleagues. Thank you for inviting me to speak in this morning's BD intervention ACS track. Okay, thank you very much, everyone. So this morning I've been tasked to talk about challenges, strategies, as well as philosophy in STEMI intervention. And we are happy to share our experience in Singapore. So as you can see, Singapore, we are a small island city-state, and primary PCI is the main reperfusion therapy in Singapore. And you can see that we have 7 hospitals that are capable of performing primary PCI 24/7. And our hospital is located in the center of Singapore.
Recording in progress.
And we do about 450 to 500 primary PCI per year. So for any primary PCI program to be successful, there are 2 key elements. So what we call the 2 Ps. So very important is the process and then followed by the procedure. And the goal of any effective primary PCI program is to achieve a door-to-balloon time less than 90 minutes. Why this is so? Because studies have shown that when you have a door-to-balloon time less than 90 minutes, it is associated with a lower in-hospital mortality for the STEMI patients. So that is why 90 minutes is considered as an international benchmark. So when it comes to process, what it refers to is the systems of care in place. So when you have to work very closely with your emergency department colleagues, because when the patient presents to the hospital, you have to triage them very quickly and perform ECG usually within the first 20 minutes. And when you promptly identify that they have STEMI, what the key elements of a primary PCI program is the ED physician can directly activate the cath lab. And we have a system where the operator will call everyone, especially if you are in after office hours, for the on-call team to come back to the hospital to perform the primary PCI. And it's very important that we arrive within 20 minutes after being activated. So how are we doing in Singapore? This is some of the results from the Singapore Myocardial Infarction Registry. So from this registry, we can see that the median age of patients having heart attack in Singapore is about 58 years old. 50% are anterior STEMI. And about 28% of patients are diabetic. And I think because of the size of Singapore, where we have quite a good transport system, the median door-to-balloon time is about 65 minutes. So well below the international benchmark of 90 minutes. So is it a job well done that we should pat ourselves on the back? I think the answer is no, because this study that was published in 2013 showed that there is a threshold limit to door-to-balloon time. And as you can see that after you lower down to about 7 minutes, the mortality does not change. So I think now the emphasis has shifted to what we call total ischemic time. So the important thing is the symptom onset to re-emphasis on. And we all know the adage that time is muscle. So we can see that your infarct size will increase as with time if you do not achieve a reperfusion. So in Singapore, what we found out is that the symptom onset to reperfusion time is about 3 hours. So we need to, again, very important to educate our patients that, when you have symptoms suggestive of a heart attack, you must get yourself to the hospital ASAP. So the second key element of an effective primary PCI program is the procedure. This is what we do in the cath lab. So not too long ago, maybe 10 years ago, how do we treat patients with STEMI? I think a lot of us remember that we use femoral access. We do routine thrombus aspiration. And a lot of us will have no hesitation to use a bare metal stand, and we just treat the culprit only. Things have changed over the last decade or so. I think firstly, we talk about radial access. I think this is the rival study that has shown that in STEMI patients, if we use transradial, it will reduce the primary outcome and mortality. It is associated with lower all-cause risk and vascular complications. So bleeding is the main driver of lower mortality in the setting of STEMI. There is a signal that patient may have increased risk of stroke. So currently, it should not be performed routinely, and this is a class 3 indication by the ESC guidelines. However, for some certain subset of patients, especially with large residual thrombus, I think there's still room for thrombus aspiration. So there are many devices that we can use, especially patients with large persistent thrombus. And one of the devices we use in the cath lab is the Penumbra Indigo system. So this is where it comes with a machine with a very powerful continuous vacuum suction. And this is quite useful for patients with high thrombus burden. Another devices that is under investigation is the stent retriever devices. This was first used in patients with ischemic stroke, and there are two as a bailout. So just show you a case example. This is a patient with a large thrombus in the right coronary artery, and we put in a Solitaire stent retriever 6-volt times 30. And after that, we remove it. You can see that the artery is clear of thrombus. And this is what we retrieve from the artery. Again, this is under investigation, so we will have to await the results of the registry as well as the RCT. So when you are confronted with large thrombus, but in primary PCI is, first of all, don't give up too easily. Principle is to establish the TIMI 2 to 3 flow. Sometimes it's important to defer our strategy. We treat the patients with IV heparin or 2B3As. And then for some patients, maybe we have to use low dose intracoronary thrombolytic. And also, like I mentioned, we use the stent retriever or the Penumbra suction device. So the second area that I would like to talk about is about coronary stenting. I think stenting is considered the norm in primary PCI. In the past, we used bare metal stent, but I think studies have shown that DAS should be the standard of care, especially it is associated with much lower TLR, and it has received a Class 1A indication in the ESC guidelines. We have many DAS in our shelves, but can any particular DAS make a difference for your STEMI patients? So one of the most contemporary trials is called the BioSTEMI trial, which compare the use of the Osiro DAS versus Zymes in the setting of primary PCI. And what they have shown is that at 12 months, you have a lower TLF target lesion failure with the Osiro stent. And this is mainly driven by reduced ischemic-driven TLR. So why is Osiro seems to be a bit more favorable? As you know, Osiro is an ultra-thin strut, especially if your size is below 3 mm. And because of the thinner strut, there is less flow disturbance, and the endothelialization process is much faster. So perhaps this is why Osiro DAS seems to do better in the setting of primary PCI. One thing that we need to be aware of is that the stent thrombosis rate in the STEMI setting can be quite high compared to elective PCI. If you look at some of the previous trials, comfortable AMI and examination, the stent thrombosis rate can range from 1 to 3%, and it does increase with time. And one of the challenges when we do primary PCI is that, so again, stenting may not be the most appropriate therapy in the setting of AMI. This is called the Revelation trial that was published in JACC 2019. So what they did was to compare two arms of patients, 60 patients receiving DCB and 60 patients receiving the Osiro DAS. You can see that they performed thrombosuction in about 80% of patients. They do pre-dilatation in 100% of patients, and DCB was used successfully in 82% of patients. About 18% of patients require bailout stenting for recall or severe dissection. And when it comes to the primary endpoint, they use FFR at 9 months as the primary endpoint. It is quite similar. But when it comes to the hard clinical endpoints, you can see that, again, cardiac death, recurrent MI, and TLR rate is quite low and comparable between both arms. So what the study conclude is that DCB strategy is non-inferior to DS at 9 months, and it is a safe and feasible strategy. So use of DCB in the setting of primary PCI is safe and feasible.